webinars because, okay, great. Now it's correct. Okay, I just added that the recording of today's webinar will be available on the Owca YouTube channel soon, so you can see it once again or provide to your colleagues just to see the presentation. Today's webinar is one of a series of webinars. We have planned a total of 10 webinars, which we started 4 months ago. In February, we had the first webinar, and the next meetings will be held in the following months until the end of this year. So each webinar will last 30 minutes with approximately 20 minutes for a presentation and 5 to 10 minutes for a QA session and discussion. And now you can see on the slide the whole set of webinars. We are just in the middle of the set of the series, and today the title of today's presentation is TDM in clinical trials: optimizing therapy and personalizing treatment. And I would like to introduce our speaker for today, Mr. Michal Owca, from Jagiellonian University Medical College. Michal is an active member of Owca Working Group 4. And I know that Michal will introduce by himself. So, Michal, please proceed. The floor is yours.
Thank you very much, and welcome everybody. Thank you for joining. I'm going to share my screen in a second. I hope you can see that.
Yes, we can see. We can see the presentation.
If there is anything, please let me know, because sometimes there are some issues with connectivity, as always. So hello, I'm going to my name is Michal Owca. I'm going to introduce myself in a second on the second slide. However, first of all, I would like just to let all of you know why we are meeting today, because it might not be very, I would say, obvious. We all, or most of us, know what TDM is, so Therapeutic Drug Monitoring. However, I'm going to talk a little bit about how it works and how it is used in clinical trials industry, because my other job and also my huge interest is clinical trials. I work in this field. I have started to work in this field like 6 years ago. Of course, the whole topic is very complex, so we cannot talk about everything. That's why we are going to focus on 3 very main let's say things, that is enhancing treatment, that is personalizing therapies, and also optimizing dosing. We are also going to talk a little bit about safety, because it's crucial for every clinical trial. As I said, my name is Michal Owca. My background is pharmacy. I'm a pharmacist who graduated from the same university as I do research right now, so Jagiellonian University in Krakow, so south of Poland. On a daily basis, I work in a CRO as clinical trial senior project coordinator within a product management department. I work basically with new therapies, with new drugs, and also with medical devices that are being checked mostly on humans. That's why I would like to touch the base and tell you from the inside how it works. The other side is also Jagiellonian University. I work there with Pavel as academic teacher, lecturer, given classes of clinical and also standard pharmacology. I'm also a community pharmacist, registered pharmacist from time to time, and I'm also a very proud Owca member. Personally, I'm a very keen person on traveling, as you can see from the pictures here on the right side, and I'm also a dog dad of these 2 little gentlemen on the right side, Rysiu and Romek, two French bulldogs who are apparently sleeping somewhere below the desk. So I'm very sorry for any snores if you can hear anything. That's usually the case during my lectures. Okay, in a nutshell, I would like to introduce you to therapeutic drug monitoring. To these of you who are not aware of what it is, I think most of you are. However, if you do not, TDM, which stands for Therapeutic Drug Monitoring, is a branch of clinical chemistry and also clinical pharmacology that specializes in the measurement of medication levels in the blood of the patient. TDM enhances efficacy and also safety in clinical trials. And as you will see in a second, these two things are crucial to, let's say, to make this whole trial happening, and at the very end to receive an approval from regulatory agencies. TDM focuses on the principles and also on applications of personalized medicine. We are going to talk a little bit about dosage adjustments, because TDM is going to help you very nicely optimize drug doses based on individual patient responses. It's going to help you to improve therapeutic outcomes through tailored treatment plans. That's why we are talking about efficacy improvement. And the third thing is, I think, the most important one, always safety first, so safety enhancement. TDM is a very great factor that is going to, and also a tool rather, that is going to help you minimize adverse effects by closely monitoring drug levels. This is what our pharmacovigilance department do in the companies. I would like to very briefly tell you, to these of you who are not very much familiar, how, in a nutshell, a clinical trial looks like. Of course, it's a very common scheme I have just prepared here. However, of course, each trial is going to look a little bit different. It depends on the design. However, overall, we usually have 4 phases and 1 phase that is preclinical. However, we are not going to talk much about preclinical phase, because here we are mostly checking if our new molecule, new drug we want to test, we test them on mostly animal right now. Then, as you can see, we have 4 phases, and each phase will have a little bit different goal we want to reach. Starting from the first one, this is where we are going to check safety and dosages, and also to maintain the right dose. We would then like to check in, let's say, further trials. The goal here is to assess safety and also tolerability, to assess pharmacokinetics, and to determine safe dose and also safe ranges of these doses. Usually, the population here is pretty small. It depends, of course, on the study itself. However, usually it's around 20 to 100 volunteers or patients. We say about healthy people. However, it also depends, because as you can see, as you can imagine, let's say we have an oncological drug. Of course, we are not going to treat anyone without cancer with oncological drugs, right? So it depends. It would not be ethical. Phase 2, here our goal changes a little bit. We want to assess efficacy, and also we are going to do the whole monitoring of side effects, and also we might refine the dose that we have been working on in the phase 1. Phase 3, of course, it's a continuation. We are going to compare our new treatment that we are working on with current standard of care, and also we are assessing efficacy and adverse events if there are any. Usually, of course, there are. Every adverse event needs to be reported, and at the very end, all of these reports, they have to be transferred to the regulatory agency that will eventually give you the approval. So this drug reaches the market or not. And then at the very end, phase 4 is a post-market monitoring, mostly to monitor very long-term safety and also effectiveness in the general population, because usually this drug is available for a very range. A big range of population. As you can see here, I think you can already connect the facts from what we have talked before. As you can see, mostly in phase 1 and phase 2, we are working to determine safety and also dosages. And also, I would say monitoring side effects might be connected. However, mostly here, we are going to use TDM, so Therapeutic Drug Monitoring, to check safety, to check dosages, and to maintain with what we are working for. So as you can see, TDM is very useful. Of course, it's going to be a little bit different while checking safety, dosages, determining pharmacokinetics, and so on. However, I would say it's very popularly used method with which clinicians are going to work with. How do we use TDM in clinical trials? I would like to give you a few of examples. Here, of course, I'm not going to talk much about that because that would be really complex speech. However, I would like to focus on 4 very main aspects. First of them is assessing patient adherence, which is, I think, one of the most beneficial thing for person that is being treated. TDM is going to help clinicians to detect whether patients are taking the investigational medicine product as required or not. Of course, it's also here, it depends what is the design of the study. However, if we have, let's say, outpatients that do not take these medicines outside, so in the hospital, here that would be very helpful to check via TDM if these drugs are present in the bloodstreams or not. Why it's so important? Because low or absent drug levels may indicate non-adherence. That's going to help investigators, so the doctors usually interpret efficacy and safety results more accurately. Here I found one very interesting paper. That was a multi-center randomized clinical trial that was published in the American Journal of Hypertension. And here they investigated whether TDM could improve drug adherence and also blood pressure in patients with uncontrolled hypertension. As you can imagine, the study found that informing patients about their low or absent serum drug levels, it improved adherence. So as you can see, it really has its meaning in the clinic. The next one, personalized dosing based on metabolic profiles. Of course, everyone is different, and our metabolisms are also different. TDM helps to adjust doses according to very individual metabolic rates, especially in these drugs that are metabolized, for instance, by polymorphic enzymes. For instance, here, phenytoin is one of these examples that are being metabolized by cytochromes, and here, but it's also very commonly used in antileptic and also psychiatric drug trials at all. So not only phenytoin. However, I have also found two studies, pretty new ones. One is from this year, 2025, and the other one I think is from last year. These studies have shown that TDM is particularly useful for first antileptic drugs such as phenytoin, which are metabolized by two enzymes. This is CYP2C9 and CYP2C19. In patients with mutations of these enzymes, a slowed metabolism has been observed. That's why it led to toxicity when standard doses were used. That's why it gives you an example why it's very important to measure these doses, these levels, so toxicity is not reached. Okay, and the next one, I would say monitoring of immunosuppressants or biologics. As you are, I hope, or you might be aware, sorry, right now biologics are very commonly used, but also very commonly researched. For instance, you can ensure that therapeutic levels of infliximab or tacrolimus are maintained in the trials of transplant or autoimmune diseases. It also prevents rejections or disease flares while avoiding toxicity. And here I found a very interesting paper from the Crohn's and Colitis Foundation. That article discusses proactive TDM, which involves evaluating through concentrations and anti-drug antibody levels to optimize biological therapy. That approach aimed to improve responses rates and prevented primary non-response and also secondary loss of responses by targeting optimal drug concentrations for both infliximab and also adalimumab. So I think very, very interesting article. And the last one, evaluating drug-drug interactions. There are, as you know, many indications where you usually do not use only one drug. Sometimes you have to use a lot of them, and such instances are, for instance, HIV. However, and very commonly one, let's say drug A can have influence on drug B, and drug B can have influence on drug A, and also on metabolism or clearance of each other. That's why it's really important to use CDM to prevent such instances, or to reduce or just adjust doses. There was one paper on COVID-19 treatments, especially for ritonavir. The study has emphasized that role of TDM in identifying and managing significant drug-drug interactions, ensured safety and also effective treatment. And as you can, and if you don't know, we use the same drug ritonavir also in HIV treatment. So it's a lot, I have to say. It's really a lot. We have a lot of literature. However, these are just 4 examples or of how we use TDM in clinical trials. However, we also have a lot of challenges in clinical trials, dosing strategies mostly. I'm going to focus on 3 that are, let's say, the most common.
So you have just 5 minutes to.
It's okay.
To finish, okay?
Thank you very much. So it's diverse genetic and also physiological factors that can influence drug metabolism. This is toxicity, and this is also suboptimal efficacy. Dosing strategies in clinical trials are very complex, and they can pose several key challenges that can significantly impact safety, trial success, and at the very end, regulatory approval. You can see, I'm not going to go into the details. However, here on the left side, you can see the key challenges that in clinical trials, I would say, have the biggest impact on dosing strategies. What more I would like to say today is that enhancing efficacy and also safety through real-time monitoring is something that also should be considered while talking about TDM. Why? Because real-time monitoring improves efficacy and safety, and this is what we really aim to have. And also it enables timely adjustments to dosing regimens. Two last things I would like to talk to you about, because of course there are some clinical trials that have very successfully used TDM, and here I would like to show you two instances, one from oncology and the other one from immunology. The first one is a study where irinotecan was exposed. Its exposure was measured by monitoring its active metabolite, that is SM38, and dosing was adjusted based on measured metabolites area under the curve. AUC in real time for each patient, and here you can see that that improved safety was seen. Significantly fewer patients experienced severe neutropenia. The other outcome was maintained efficacy, so because response rates and progression-free survival were comparable or slightly even improved. And also TDM guided dosing was operationally feasible in multi-center settings. So here it was demonstrated that it's feasible. While the other trial within immunology, here we had patients that were already in remission and they were on infliximab. And here we had two cohorts. First of them were we had a group that was TDM guided, and they were dosing just to have, let's say, drug serums between given levels. And the other one was just clinically guided group with standard care. Based on the symptoms and also the CRP. And here you can see also very good results, improved efficacy, lower immunogenicity, but what is also important, it was found out that TDM prevented unnecessary dose escalation in some patients, while optimizing efficacy in others, what has shown cost effectiveness, so money. At the very, very end, I would like to present you what we are doing right now in our department. We are trying to reach some data from healthcare professionals on the utilization of therapeutic drug monitoring for biological treatments across countries of Europe. Right now we are in the stage of collecting data. If any of you would be interested, of course, please let me know. This is just the introduction of the survey we are sharing with healthcare professionals. And as I said, we are completing the data to work on some very nice paper in the future. Thank you very much. I'm going to leave you with some literature I used, and that would be all.
Webinar. And okay, thank you for attending and participating, and see you at the next webinar next month.
Thank you all. Thank you very much.
Thank you. Bye.
Thank you very much.
Bye.